Call the meeting to order. Welcome to meeting number 12 of the House of Commons Standing Committee on Health. Today we meet for 2 hours to hear from witnesses on our study of the emergency situation facing Canadians in light of the COVID-19 pandemic. Before I introduce today's witnesses, a few regular reminders for hybrid meetings. Today's meeting is taking place in a hybrid format pursuant to the House Order of November 25th, 2021. Members are attending in the room, and we have one attending remotely, Mr. Davies, I believe, using the Zoom application. We will, of course, keep a consolidated speaking list and try to pay attention when you indicate that you want on it, Mr. Davies. Of course, you're aware that screenshots should not be taken during the meeting. The proceedings will be made available via the House of Commons website. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting. And with us here today, we have, as an individual, Dr. Shirin Kalian, Adjunct Professor of Medicine at the University of British Columbia, d'Amnesty International Canada francophone, France Isabelle Langlois.
France Isabelle Langlois from Amnesty International Francophone Canada. She's the Executive Director, and Colette Levièvre, Campaign Director.
Mental Health Association, Margaret Eaton, the National Chief Executive Officer. From the Canadian Psychological Association, Karen Cohen, Chief Executive Officer. From the National Advisory Committee on Immunization, Dr. Brina Warshawski, Medical Advisor. From the Ontario Association of Radiologists, Dr. David Jacobs, President and Diagnostic Radiologist. Thank you to all of the witnesses for taking the time to appear today. We have a very esteemed and plentiful panel, and we certainly look forward to the discussion. We're going to begin with opening remarks from each witness in the order they appear in the notice of meeting. So that makes you first, Dr. Kalian, and you have the floor for 5 minutes. Welcome to the committee. Please go ahead.
Thank you, Honourable Speaker, and committee members for the opportunity to speak today. The thoughts I'm presenting are my own as an immunologist and not necessarily those of my affiliated organizations. I submitted notes that contain further data and references for the issues I'll be addressing today, which involve Canada.
Monsieur le Président, point d'ordre. Le son est beaucoup trop fort pour que je puisse entendre quoi que ce soit d'une traduction. Alors, il faudrait vraiment baisser le volume en salle parce que je comprends rien. J'ai comme 2 discours qui me rentrent dans les oreilles à même hauteur.
Oui, okay.
Mr. Chairman, unfortunately, the room sound is too high, and it's interfering with my understanding of the interpretation.
Just to, okay. Dr. Kalian, could you if you could start again from the top, we'll restart the clock, and hopefully the volume is a little more regulated. We have.
Did you want me to speak louder?
We have you coming through the speakers, but you're being simultaneously translated, and both need to work. So try again, and if there's a problem, I'll interrupt again.
Okay. Let's dig to. And so I thank everyone for the opportunity to speak today. The thoughts I'm presenting are my own as an immunologist and not necessarily those of my affiliated organizations. I'd submitted notes that contain further data and references for the issues I'll be addressing today, which involve Canada's vaccine mandates and the manner in which they have been implemented, which include the lack of recognition of infection-acquired immunity and the suboptimal data collection and availability required to evaluate the efficacy and consequences of the public health policies and mandates to guide evidence-based decision-making. So anytime a medical intervention is mandated, it needs to meet a fairly high bar for its justification. We should have a solid understanding of both the safety and efficacy of the intervention. Its purpose needs to be clearly stated, and we need to ensure that we have in place an ongoing surveillance to evaluate how well it is working to achieve its stated purpose. Now, with that base, a vaccine mandate may be justifiable if there was clear evidence that the vaccines we are using reliably prevent disease and its transmission. We have a clear grasp of their safety profile, which should be acceptable for prophylactic use for the disease in question. The mandate is not overly broad or unreasonable, and those subjected to the vaccine mandate can provide informed consent, which requires them understanding their own personal long and short-term potential risk from vaccination in view of their own personal risk of severe disease from infection. Now, it is clear, especially with Omicron, that the vaccines we have cannot really be relied upon to either prevent transmission or infection. An example, the first Omicron case in Israel came from a triple vaccinated doctor returning from a conference who passed it on to another triple vaccinated physician. The Omicron spread into many countries has been through fully vaccinated, often boosted individuals, and this really questions the validity of the current vaccine mandates for travel within and outside of Canada. Now, data from Ontario and other jurisdictions from around the world show vaccine efficacy drops below 0 after the end of the second month in those who are fully vaccinated, and boosters appear to show a similar rapid timeline for waning. So with this evidence, we should have moved quickly to lift heavy-handed measures and explain the evolving evidence. This is necessary for public trust. It is also good for public health to have a well-informed populace. Having a false sense of security has obvious negative consequences. So when it became evident during the Delta wave that the mRNA vaccines had poor durability in their ability to prevent infection and transmission, the messaging justifying mandates had shifted to the prevention of hospitalization and serious disease. And if that was a new purpose, then Canadians with infection-acquired immunity should have had their superior immune protection recognized from the onset. The data have been unequivocally clear that those who have had COVID-19 and recovered are better protected, as would be expected, from infection, serious disease, and death compared to those who are fully vaccinated. They would have also been less likely to transmit infection if they get reinfected, as their greater mucosal immunity limits viral replication better. Unlike those who are fully vaccinated who experience a first breakthrough infection, who can have viral loads very similar to immune-naive individuals. Now, recent data from the US CDC confirms that vaccinating those who have infection-acquired immunity really provides them no real additional benefit. Thus, these already immune individuals are primarily being exposed to unnecessary risks, as rare as they may be, and they're also more likely to experience adverse effects following vaccination. So this lack of risk stratification for the blanket vaccine mandates has also been poorly considered for emerging vaccine-associated serious adverse effects. When the signal for vaccine-linked myocarditis appeared, it was repeatedly conveyed that the risk was far less than after COVID-19 infection. Now, data show that actually for males under 40, the risk of myocarditis is in fact greater after vaccination than following infection. The erroneous statements previously made in respect to this risk were never publicly corrected, which means that these individuals haven't been given the opportunity to provide proper informed consent. We're requiring those who are probably among the least likely to experience serious disease to be subjected to a medical intervention for which they bear the greatest potential risk of a non-trivial nature. Now, as we move into the endemic phase of COVID-19 with Omicron, I hope we take the opportunity to investigate how we could improve our strategy, especially around blanket mandates for future pandemics, because they do have consequences. I'll just close now with the statements made recently by the head of vaccine strategy of the European Medicines Agency, the EMA, who had spoken directly to the lack of data and sustainability of continuing down the path of multiple boosters as a rational approach to the pandemic at this time. The EMA is aware that such an approach may actually do more immunological harm than good, and it is their position that further data is needed for the Omicron variant, particularly in respect to the utility of the current vaccines and whether different types of vaccines are needed now. Given the evidence and its lack, I feel this is the most reasonable and responsible approach. I thank you again for the opportunity to speak to these issues.
Thank you very much, Dr. Kalian.
Merci, Dr. Kalian. La parole va maintenant à Amnesty International, Canada francophone.
Exécutif, France-Isabelle Langlois, à vous là.
Merci. Mesdames et messieurs, bonjour. Merci de l'invitation.
Ladies and gentlemen, thank you for the invitation. The health and the lives of Canadians in a global pandemic depends on the health of all humanity. Amnesty International, as a human rights organization, has intervened from the very beginning of the pandemic to call for unwavering international solidarity from all states, including Canada. Under international human rights law, states have an obligation to provide the financial and technical support necessary to implement the right to health, particularly in the face of the international spread of a disease. We therefore call on Canada to strongly support the proposed temporary exemption to or derogation from intellectual property protections for health technologies related to COVID-19 proposed by South Africa and India in October 2020 at the World Trade Organization. However, we are deeply concerned about a draft text, which was leaked to the media, proposing a compromise for this exemption between the European Union, the United States, India, and South Africa, which appeared to be under consideration last weekend. As written, this text cannot ensure the supply and transfer of technology that is critical for equal access to healthcare tools against COVID-19 and to protect the right to life and health. We urge Canada not to endorse this text. The original waiver of the TRIPS agreement at the WTO, requested by India and South Africa, is intended to democratize the production of instruments to fight COVID-19 until global herd immunity is achieved. The World Health Organization has recognized the role of large-scale immunization against COVID-19 as a global health-related public good to prevent, contain, and eliminate the spread and end the pandemic. Yet pharmaceutical companies around the world are continuing with business as usual, limiting production and supply capabilities. We will have to live with COVID-19 for years to come. Everyone must have access to vaccines, but also to treatments. Production must be democratized, especially now that new treatments are becoming available. By supporting the removal of intellectual property protection for vaccines and other products against COVID-19, Canada can put the lives of people around the world, and therefore of Canadians, ahead of the profits of a few pharmaceutical giants and their shareholders. The only way to end the pandemic is to end it globally. The only way to end it globally is to put people before profits. The international human rights standards and international trade regulations to which Canada adheres are clear. Intellectual property protection must never come at the expense of public health. The COVID-19 crisis is also a human rights crisis. It cannot be overcome without a real commitment to one of the Sustainable Development Goals, namely leaving no one behind. Based on the premise that no one is safe until everyone is safe, Canada has an opportunity today to make a decision that can help us all achieve this goal. Amnesty reiterates its call on the Canadian government to support the exemption request in its entirety. We call on Canada to show exemplary leadership in the area of international solidarity. Thank you.
Merci, Madame.
Thank you. Ms. Langlois.
Canadian Mental Health Association, the National Chief Executive Officer, Margaret Eaton. Ms. Eaton, you have the floor for the next 5 minutes.
Thank you so much. Hello, I'm Margaret Eaton. I'm the National CEO of the CMHA. And CMHA is the most extensive community mental health network in Canada. Founded in 1918, we have 330 community locations in 10 provinces and the Yukon Territory. We reach over 1.3 million people each year, and we employ 7,000 Canadians. CMHAs are independently governed charities that deliver free mental health supports to anyone who needs them, from counseling and psychotherapy, substance use treatment and youth programs, to housing and employment services. CMHAs keep people out of hospitals by intervening early to promote mental health and prevent mental illness. Our recent research shows that most Canadians worry that COVID will never go away. 64% of Canadians are worried about new variants, and 57% are worried about COVID-19 circulating in the population for years to come. The chronic stress of dealing with the pandemic is taking its toll, and it makes basic decisions harder, it saps our energy, and it leaves people tired and burned out. As you know, we've all been in the same storm for the past 2 years, but we haven't all been in the same boat. 40% of Canadians say their mental health has declined since the onset of the pandemic, and this spikes in vulnerable groups, such as those who are unemployed due to COVID-19, those who had a pre-existing mental health condition, people who identify as LGBTQ2+, young people, people with a disability, and people who are Indigenous. Vulnerable peoples have just experienced much worse mental health over the last 2 years. These significant inequities have made it impossible to ignore the long-standing service gaps and systemic barriers in our mental health system. Our research shows that almost 1 in 5 Canadians felt they needed help with their mental health during the pandemic, but they didn't receive it because they didn't know how or where to get it, or there was no help available, or they couldn't afford to pay for it. Millions of Canadians rely on free mental health and addiction services and supports provided by the not-for-profit sector, but these organizations are strained to the breaking point. Community mental health care workers receive lower wages, have higher work demands, experience compassion fatigue, and are more likely to experience burnout than other healthcare workers. But despite these difficult conditions, they have creatively and compassionately met people's needs. When there was no housing available and food banks closed, CMHAs purchased tents and had food boxes delivered. Some CMHAs called their entire wait lists to see how people were doing and offer whatever supports they could. Some launched new crisis lines and chat services to give isolated people a friendly conversation and a wellness check-in. But this emergency mode isn't sustainable either for our staff or for our clients who need stable long-term help. 2 years in, we've moved from crisis to chronic. And even if the immediate impacts of COVID-19 are subsiding, the mental health effects persist and will likely continue for years to come. The community mental health and addiction sector cannot meet these growing needs with the current patchwork funding and disjointed service delivery model. It's time to overhaul our mental health system. CMHA calls on the federal government to do these 4 things. 1, establish long-term and stable federal funding for key programs, services, and supports delivered by the community mental health sector. Number 2, invest in mental health promotion and mental illness prevention programs and strategies. Number 3, publicly fund community-based counseling and psychotherapy. And number 4, invest in housing, income supports, and food security. We must integrate community mental health services into the healthcare system, and we must ensure that provinces and territories are held accountable to how federal funds for mental health are spent. We have a critical window of opportunity to transform Canada's mental health system. Let's not miss it. Thank you.
Thank you very much, Ms. Eaton. Next, Dr. Karen Cohen, Chief Executive Officer of the Canadian Psychological Association. You have the floor.
Thank you very much for the invitation to appear before you today. The psychological factors implicated in the COVID-19 global pandemic are several. First, successful management of health and illness depends on how people think, feel, and behave as individuals and in groups. Wearing masks, keeping physically distant, getting vaccinated, all involve making decisions and changing behavior. Psychological science is critical to the success of public policies intended to bring about these changes. Dr. Kim Lavoie, Canada Research Chair in Behavioral Medicine, has shown that to increase vaccine uptake, different approaches are needed depending on why someone has resisted vaccination. Dialogue and education may work for people who are afraid of or lack trust in vaccines, whereas mobile vaccine clinics work with people who haven't gotten vaccinated because they can't leave work or get to a clinic. How health providers talk to their patients who resist vaccination will impact whether they change their minds. Policies affecting people will be more effective if they take into account how people think, feel, and behave. Second, while too many Canadians have contracted the COVID-19 virus, every Canadian has lived its psychological, social, and economic impacts. Recent surveys of the psychological impacts have shown that nearly half of Ontarians said that their mental health has worsened since the pandemic began, which is up from 36% when the pandemic started. More Canadians continue to report high levels of anxiety and depression now than when the pandemic began, and more Ontarians are accessing mental health support now than at any other time during the pandemic, but 43% have said it is difficult to get help. While self-reported mental health problems and reaching out for professional help may have increased, timely access to psychological services has not. When asked about barriers to accessing psychological services, a 2021 CPA Nano survey showed that more people cite financial factors than stigma. Unless the psychologist is salaried in a public institution like a hospital, their services are not covered by Medicare. As public institutions face budget pressures, there are negative impacts on the number of salaried positions and on conditions of work. Increasingly, psychologists work in the private sector where their services are inaccessible to those who cannot afford them. Even when psychological services are covered by private health insurance plans, the median amount of coverage is $1,000 annually, which is less than a third of what it costs for the average person to have a successful treatment outcome. The CPA, in collaboration with provincial and territorial psychological associations, has just issued a paper entitled New Federal Investments in Mental Health, Accelerating the Integration of Psychological Services into Primary Care. We outline ways in which some provinces have addressed this service gap and how the federal mental health transfers can reduce this gap further still. Finally, as Canada redresses the funding barriers Canadians face in accessing psychological services, there are other barriers needed. For effective mental health human resource planning, we need to collect better data. While we have some data about the demographic and practice characteristics of health providers whose services are delivered under Medicare, we know very little about health providers like psychologists whose services are delivered in the private sector. A large class of students training to become psychologists is 10, compared to the hundreds of students in medical or nursing classes. To better meet the diverse mental health needs of Canadians, we need to train more psychologists. The pandemic has shown us that much mental health care can be delivered virtually. The regulation of Canada's health providers is done provincially and territorially. Entry to practice requirements vary from one jurisdiction to another, and a health provider cannot necessarily provide services outside their province of registration. While the Agreement on Internal Trade and the Canadian Free Trade Agreement mandated health regulators to ensure mobility, these federal directives did not give regulators the authority to set common licensing requirements. When it comes to healthcare, the pandemic has underscored the limitations of systems that are provincially and territorially based rather than nationally based. In summary, global health crises have mental health impacts, and the successful management of any global health crisis depends on psychological factors. To address these, we must develop pandemic policies that are informed by psychological science, redress funding barriers to accessing psychological care, and attend to the training and regulation of Canada's health human resources. Canada has no health without its mental health. Thank you.
Thank you, Dr. Cohen. Next, on behalf of the National Advisory Committee on Immunization, Dr. Brina Warshawski, the medical advisor. Dr. Warshawski, the floor is yours.
Thank you very much, Mr. Chair. I have no opening remarks, but I'm happy to take questions at the appropriate time. Thank you.
Well, that gives us an extra 5 minutes for questions. Thank you. Representing the Ontario Association of Radiologists, Dr. David Jacobs, President and Diagnostic Radiologist. Dr. Jacobs, you have the floor. And you're on mute there, Dr. Jacobs.
Mute. Okay, can you hear me now?
We can hear you. Welcome. Go ahead.
Fantastic. Thank you so much. I was just admiring the previous speaker's opening remarks. I think that's brilliant, and I'll do that next time. What I'm going to do is just give you a very brief look into healthcare through the eyes of my specialty, which is diagnostic radiology, and how it's impacted patients and how it's impacted healthcare in general. Diagnostic imaging and interventional radiology is a subspecialty in medicine. And what we do is we interpret images, CT, MRI, mammography, and we also perform procedures, breast biopsies, basically biopsying any solid tumor from head to toe, angiography, and other interventions. So our services were highly used during the pandemic. So prior to the pandemic, we had wait lists that far outstripped what was mandated by government. And what we found during the pandemic, despite a large drop in utilization of hospital services outside of COVID-19, we found that the wait lists skyrocketed. And there are a number of reasons for that. And again, I want you to think of this not just with diagnostic imaging, but with medicine as a whole. Wait lists for all interventions and all specialist appointments skyrocketed during the pandemic. And really what it came down to was access to imaging, access to healthcare. When we went into pandemic mode, we forgot many of the lessons that we had learned with the first pandemic, with the first outbreak of SARS. Now, this has been a much more dramatic pandemic than the initial SARS. But what we didn't do is we didn't do a very good job of compartmentalizing risk and compartmentalizing need. So what we ended up doing was basically shutting the system down. We assigned the same level of risk to all procedures, and we assigned the same level of risk to all interventions. Right now, we have over 1 million Canadians on wait lists for CT and MRI. Over the course of the pandemic, our wait list ballooned for MRI from what was an unreasonable but acceptable 3 months or so for an MR examination to over 9 months for some centers. Delayed diagnosis had a major impact. So as we saw waves of COVID going through the population, one of the unfortunate things that we saw were malignancies that were coming in that were very much delayed. So what had been seen early in the pandemic or just prior to the pandemic, when we did the follow-up studies because of lack of intervention and delay in ability to get the imaging that was necessary, what we would see were cancers that started off as resectable, as treatable, that became unresectable or palliative in nature in terms of what we could offer the patient. That's unacceptable. And the causes are multifactorial. Some of the causes that we could change is not shutting down low-risk procedures like medical imaging, CT scans and MRIs. We basically turned the key, turned everything off, and shut down the system. We can't do that again. It had a major impact on screening services such as mammography. We have 300,000 women who were not screened. That will unfortunately result in an increase in the number of breast cancer-related mortalities in the years to come. Approximately 6.5% of all screened women will have a finding on their study which will require further workup. So I'll let you do the math on that. The other issue uncovered are human resources issues. As we came out of waves, money was sent to increase the number of studies that we could do to play catch up. But what we found is we simply didn't have the human resources to catch up on those studies. Mostly it had little to do with radiology, but it had radiologists and physicians. It had more to do with support staff. So clearly we are not training enough technologists for radiology, nurses for the floors, and the ORs and the ICUs. So we really need to kind of think about how we manage human resources and what kind of slack we have in the system. The other issue that I wanted to talk about was stalled health initiatives. So in this 2-year period, in any 2-year period, we would see movement forward and progress in terms of how we care for patients, not just in terms of technology, but in terms of just the organization and how we and how we structure a patient's trip through the healthcare system as there are more innovations. One thing that stands out from a diagnostic imaging point of view is over the course of the pandemic, we had some studies that came through that showed breast screening should actually be done for women aged 40 to 50, which currently we don't do because of a previous flawed Canadian study. Now, we had been trying to implement that, but over the 2 years, we weren't able to. So that's one example of many where we've kind of, we focused so laser beam focus on COVID-19 that a lot of other important health initiatives fell by the wayside. So I'm happy to discuss any of these, but really I think what the fundamental point is that when we face another wave, when we face another pandemic, what we have to remember is that there is more to medicine than simply the pandemic. The pandemic was incredibly important and in many ways very well taken care of, but we neglected other areas of healthcare and we can't do that again.
Thank you, Dr. Jacobs. So that concludes the opening statements. We're now going to move to rounds of questions, beginning with the Conservatives. Mr. Lake for 6 minutes.
Yeah, thank you, Mr. Chair. This is a really interesting panel. I'm making notes here, and it's interesting to listen to Dr. Cohen talk about how we increase uptake and the different approaches to increase uptake of vaccines after having listened to Dr. Callion. It sounds like suggesting that maybe getting the vaccine right now isn't a great idea for Omicron. I may have that wrong, but both of whom have significantly stronger credentials in healthcare than I do. And so I think it creates a good opportunity. And we have NACI here represented by Dr. Warshawski, who didn't make opening comments, and I'm going to go to her first because I'm interested to hear what she thinks about what Dr. Callion had to say.
Yes, thank you very much, Mr. Chair, for the question. So the National Advisory Committee has made recommendations with regard to booster doses. They've recommended that booster doses be offered strongly for people 50 years of age and over and certain other high-risk groups, and have a discretionary recommendation for those 18 to 49 years of age, as well as for high-risk adolescents, 12 to 17 years of age. NACI is currently also looking at their booster dose recommendations for additional booster doses and also whether to strengthen their booster dose recommendations. So NACI is constantly looking at the evidence and the epidemiology to make their booster dose recommendations. Thank you.
Does NACI have a position on whether vaccines should continue to be mandated at the federal level for the folks that they're mandated for right now? For two shots?
Thank you for the question, Mr. Chair. So NACI doesn't make recommendations with regard to mandates. That's a provincial and territorial and federal jurisdiction. NACI provides recommendations with regard to what vaccines should be used and how they should be used for Canadians, but mandates is not within their scope.
Dr. Jacobs, I'll go to you and just ask you if you have anything opinion to offer in regards to, because I know that following you on social media, you're very pro-vaccine. Any thoughts on Dr. Callion's position as it relates to Omicron? It's a good opportunity to have a back and forth, and then if Dr. Callion wants to weigh in, glad to have her have the opportunity to.
Well, I think Dr. Callion has made some very good points. And I think that we also have to look at that, but I have to also look at it from a pragmatic point of view in terms of what I see in the hospital. So to Dr. Callion's point, in terms of mandates, yes, Omicron was highly contagious. And no, the vaccine didn't do much in terms of preventing spread of COVID. If it did, it was minimal. So Omicron spread very rapidly. The previous Delta and other strains, there was a more robust prevention of transmission, but for Omicron it wasn't. And that takes away some of the need for a vaccine mandate, except, and this is a big exception, what we saw in the hospital were the patients who were immunosuppressed, elderly, so de facto immunosuppressed, and the patients who did not receive a full vaccine regimen. They were the ones who were getting very severe COVID pneumonias. I saw a lot of people come in with COVID in the Omicron wave, but it was predominantly the ones who were unvaccinated, immunosuppressed, or frail elderly who were getting desperately ill from it. So from a larger population point of view, I can't make those arguments. That's more the world of NACI. But from an individual recommendation, those three groups, it would have been much better for them to have been vaccinated and boosted than not.
Dr. Callion, do you want to weigh in on this too?
Yes, thank you very much. So the trials around the clinical trials that were done never really assessed the ability of the vaccines to prevent transmission. And I haven't come across a component vaccine that is intramuscularly injected that is very effective in preventing transmission of respiratory viruses long term. So I think that understanding and having vaccine literacy is really helpful for the population. If we had an intranasal live attenuated vaccine, which would be a better type of vaccines for especially young healthy kids, for that more comprehensive trained innate immunity and launching an appropriate type of immune response to a certain type of bug would probably be a better approach to take. But we didn't understand, I think, when the mandates were put in, because we didn't have a lot of the vaccines we're using. Actually, we have very little clinical experience with. We have never used them outside of emergency use authorization. And so I think that was the surprise for me as an immunologist, that we started mandating the use of these vaccines without having, the clear data, and the companies themselves are just starting to release the the anonymized patient level data. It might take they wanted not to release that for the next 75 years, but we're starting to get some of that more clarity on the type of efficacy that really the vaccines have in a placebo-controlled trial. And so I would have, of course, want to look at the risk benefit, and that's where the risk stratification would have been really helpful to identify. We know, by May 2020, that 95% of the mortality COVID related when we didn't have vaccines were in those over 65 years of age. So I think if we had focused on, protecting the most vulnerable, would have gone farther than putting blanket mandates on everyone, because that has really, I think, that actually has the potential to increase vaccine hesitancy and trust in vaccines and the public health care system in general in terms of recommendations. And so I do believe that we should be focusing providing immune protection and being transparent and looking at the evidence when we have an immune escape variant like Omicron. How much data do we have that giving multiple boosters is going to be helpful or is good for people? So we really need to diversify. The first time I spoke to the committee members was back in June, and I'd really strongly suggested that we diversify the portfolio of the type of vaccines we have available to Canadians. And so we put all our eggs in one type of basket. And so we've seen we're still in a similar position, but with Omicron, it's a far less severe type of infection. So I understand that people who are frail and don't have good immunity, they require some type of
Thank you, Dr.
more
Callion.
protection. Yeah.
Thank you. Next, Dr. Pawlowski, please, for 6 minutes.
I wanted to question Dr. Callion too. So I wasn't sure on your testimony where you seem to question the mandates and admittedly the vaccines aren't good at preventing spread of Omicron. But you yourself acknowledged that the reason for the mandates was kind of shifted to preventing hospitalization, ICU admission, and deaths. Do you not agree that that's a valid concern, and that the government ought to be taking actions in order to try to prevent hospitalization, ICU admissions, and death. And as Dr. Jacobs has told us, the fact that all of that also undermines the ability of the healthcare system to provide other health services. So am I wrong? But you're giving me the impression that you think that we shouldn't have any mandates at all, and you don't buy the fact that and there's tons of evidence about the vaccines, even with Omicron, decreasing hospitalization, ICU admissions. And I've got from Kaiser Permanente, they said 64 to 73% less likely people are less likely to be hospitalized if they've been vaccinated. South African study, 70% reduction in hospitalization for people who are fully vaccinated. This is Omicron. And also in Quebec, people who hadn't been vaccinated were 7 times more likely to be hospitalized, 14 times more likely to end up in the ICU. This seems to me pretty good reason to be promoting vaccinations and social distancing if necessary, because those are pretty significant numbers. And even as of March 14th, there were 435 people in ICUs across Canada and 4,200 hospitalized COVID patients. So again, but maybe I'm misinterpreting you.
No, you're interpreting the data from randomized placebo-controlled trials. I'm not saying vaccines will not prevent hospitalizations, but I don't think coercion is the best way to get people to behave the way you want to. I think there are lots of health-promoting activities. If you suggested people stop smoking, that people exercise, that they reduce their weight, there are many things that would reduce a hospital surge, but we never really did a more holistic approach to improving people's health, including mental health. And so I believe that if people are equipped with the information and understand their own risk profile, it is far more effective than putting blanket vaccine mandates, especially for people who already have immunity. And so that's really where I'm coming from. We need a better risk stratification, and Canada has never had a policy around which they would mandate vaccines. There are provincial legislations for certain childhood vaccines, but people have the opportunity to opt into that. So I really believe that informing people rather than forcing them to do something is always more effective for healthcare.
If I don't know. Well, maybe I'll give the doctor from NACI, Dr. Warshawski, an opportunity perhaps to reply to Dr. Kalian, or do you not want to enter into this debate?
Thank you, Mr. Chair. I can just provide some of the facts that NACI has been looking at with regard to vaccine effectiveness. So we do know that for 2 doses, the vaccine effectiveness against infection decreases over time, and it can end up being quite low. But with 3 doses, we do see protection against infection of around 60%, and that does decrease as well over time. With severe disease, we see that vaccine effectiveness for 2 doses around 65 to 85%. And when we add that booster dose, we get protection against severe disease like hospitalization, which is in the high 90s. That may decrease over time. That's something that we're watching closely. Thank you.
Maybe can I turn my question to, I think, is it Madame Langlois from Amnesty International, and you mentioned about the movement and the ask for the WTO to drop the patent protection on COVID-related items. And you mentioned the fact that there was recently a suggestion of a compromise between India, South Africa, the EU, and the United States, which you don't support. However, I haven't heard of this compromise, and maybe if you could tell us what the compromise was and why you don't support
it. Le compromis.
The compromise is too great. What is asked for here is too much. There will be a longer timeline. There are fewer countries that could then have access to the, if you will, the recipes or the technologies and even countries that have the capacity, like Kenya or other Asian countries. It also further restricts the lifting of IP patents so that they only focus on the vaccines, whereas there are so many other technologies, there are so many other products that are and will become more and more available to treat COVID-19 and also to prevent it. These therapeutics are even more important because they can be helpful for the poorest and most disenfranchised groups in the world. We know that the cold chain for vaccines is a complex thing to manage, and it's all the more so in, let's say, African countries or in very remote areas in Africa. So the lifting of these patents has to deal with all products and treatments that are developed by these pharmaceuticals to prevent, treat COVID. The initial proposal dates back to October 2020, and now it's March 2022. And during this period, there are constantly new waves, and we're actually wasting time. Thank you, Madame Langlois. Dr. Poloski. Bloc Québécois, Mr. Thériault, you have 6 minutes, please. Thank you very much, Mr. Chairman. I'd like to thank all the witnesses for appearing before our committee. You will not be shocked, Mr. Chairman, to know that I'll be turning to Amnesty International for my first question. I'd like to thank you for being here. You're really helping us focus in a more global way on the pandemic, in a more comprehensive way. I'd like to mention that my colleagues, Dr. Poloski, Mr. Davies, and myself, publicly supported the lifting of this patent and the proposal that was brought forward by South Africa. When the first wave struck, we thought that the premise to really respond adequately to the pandemic was that we needed everyone vaccinated. If we can fight to put an end to this and for it to become endemic, that was required. We realized at that point that there was the sharing of resources when it came to research, and it was quite a beautiful thing. It was very hopeful. And then all of a sudden, vaccines are developed, and this solidarity turns into this internecine fight, and the poorest countries are basically cast aside. And so here we are, we're dealing with one wave after the next and one variant after the next in this way. Now, if you can answer succinctly, what is the state of global vaccination at this point in March 2022? What can you tell us about that? Sorry, I'll ask a couple of them and then you can get to them all. The second question I have is this. Can you tell us why you favor the lifting of these patents rather than a voluntary license system as proposed by a number of countries, including the chair of the the president of the European community? Sorry, I'm getting feedback in my ears here. I'm not sure why. The vaccine situation the world over is absolutely inequitable, unfair. The the richest countries, Australia, the U.S., Canada, Europe, are broadly vaccinated. Vaccines are broadly available. The populations within these countries that are not vaccinated are groups that we're having a hard time reaching for reasons that some of your witnesses have mentioned, or people who choose not to get vaccinated. Whereas in these poorest or middle-income countries, the situation is that we're talking about barely 4%. These are the most recent figures. 4% of the population in these countries overall has had access to these vaccines, or to an adequate level here, which would mean 2 doses of the vaccine. As I said earlier, it will be challenging. Even if these vaccines were available on site, it would be difficult to vaccinate remote populations in Africa due to the heat and the reluctance that is experienced here is also experienced there. And the longer we wait, the longer these populations will be reluctant to get the vaccines. So I'd say there's a lot of work that needs to be done. And the more we get this sense of protection here, the more we forget the rest of the world. The more we tend to forget that we are all interconnected. And so long as there's no vaccine fairness or other therapeutics fairness, then the virus will continue to spread and will keep winding around and coming back wave after wave. I mean, hopefully there will be an end to the vaccine, to COVID, but certainly this can continue for a number of years. So that's the situation globally. The second question had to do with lifting the patents versus the option of having the vaccines produced by other firms. The European Union's president suggested that option. I think you mentioned it earlier. We favor lifting the patents to make things as fair as possible and as transparent as possible, that these recipes, quote, be shared, and that where it is possible to produce vaccines, that be done. The voluntary lifting, actually the truth is pharmaceuticals are against the sharing of these patents and of the actual recipes behind these drugs and vaccines. So we can't count on it being voluntary. With respect to the supply chain, the fact of being able to produce something on site, is that not a positive when it comes to really spreading these vaccines far and wide? For instance, if you think about refrigeration and all those other factors, briefly, if you can. Yes, of course. Of course. The closer the production is to the site, the better it is. Of course, there will still be logistical challenges, especially if you're dealing with vaccines that require a cold chain. For instance, in Dakar, Senegal, because distances are so large, roads are complex to deal with, having the right equipment to keep the cold chain. This would require going beyond vaccines and having international solidarity on all levels, from logistics to production to transfer of all these technologies is important. Thank you, Madame Langlois. And Mr. Thériault.
TVs, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for being here. Dr. Kalian, you referred in your opening statement and remarks to infection-acquired immunity. How clear is the data regarding its strength and durability, and how does it compare to vaccine-acquired immunity?
So vaccines are trying to, it's actually the gold standard as far as when we recognize the immunity you get from infection, that's what vaccines are trying to mimic. And that's why our biggest successes around eradication have been from live attenuated vaccines, such as the smallpox vaccine, because they most closely mimic that infection. So we know that for COVID, it's been unequivocal that people who've had COVID and recovered are better protected from infection, obviously from serious disease and hospitalization, with the caveat that they survived the first infection. But given COVID is particularly, we know the risk factors associated with serious outcomes. There are a vast number of people who have already had COVID-19, and I think that with Omicron, we'll probably be in a better place as more people get that natural immunity.
Now, you've also spoken and touched on vaccinating those with infection-acquired immunity. I think Dr. Tam and I believe NACI, and I'll certainly let NACI have a chance to comment on this. I think they recommend vaccination for people who have infection-acquired immunity. What is your position on that?
I don't think they should be subjected to the mandate for this because their immunity does last longer than vaccine-induced immunity, and that has been shown in epidemiological studies and also recently from the US CDC data from California and New York, which showed that there was no benefit in respect to hospitalization for people who've had infection-acquired immunity and getting vaccinated. And I know we've heard a lot of this hybrid super immunity you get from being vaccinated, even if you've had COVID, but that short-term spike in serum antibody levels is, it's not really worth a mandate for.
Now, I want to talk about the issue of waning. We know that we get a vaccine, and it seems to be very effective at preventing hospitalization, serious illness, and death for a period of time. But I think in your opening statement, you said that data from Ontario shows there's a negative vaccine efficacy by the second month in those fully vaccinated, and boosters show similarly rapid waning timelines. Can you sort of expand on that, particularly what is meant by negative vaccine efficacy, and tell us how long do the vaccines stay effective?
So that the vaccine efficacy definition, even in Pfizer's and Moderna's and all the vaccine trials, original definition was for the prevention of infection, not serious disease. So from Ontario's data and also the UK surveillance, they found that people who have 2 doses who are fully vaccinated of the mRNA vaccines, as well as the viral vector vaccines, after 60 days or so, their vaccine efficacy, so you're looking at the number of cases compared to those who are unvaccinated, actually drops below 0. And that's been a consistent finding. It is not so unusual with an immune escape variant. So when you're focusing all your immune attention to one particular antigen of a virus, you're obviously going to be selecting for one that is not recognized by the population's immunity against that particular pathogen. So that's why I think component type vaccines are more likely to select for immune variants as opposed to more whole, either live attenuated or perhaps whole vaccines are harder to make.
Well, you've kind of anticipated where I was going next, which is the types of vaccines. Can you maybe briefly review for us the different types of vaccines and provide your assessment of the current Canadian options for those different types of vaccines?
Yeah, so unfortunately, so this is what I'd spoken to previously, we didn't have capacity. I'm glad to hear that we have invested in having our own GMP manufacturing capacity, and hopefully we'll get the expertise needed to make the type of vaccines that we feel would benefit Canadians. So, we have the whole type of vaccines. Live attenuated vaccines are best actually for children because it exercises the immune system really well. And they're basically a version of the bug that is being attenuated, or so they're not as infectious. You're sort of handicaps the bug and you launch an appropriate type of immune response to it. And so that examples of that, the smallpox vaccine, the measles vaccine, and those are really effective. You don't need to go down this multiple dose issue. The next are then you have whole inactivated vaccines. So you basically take the bug, you kill it in some way, and then you add hopefully an adjuvant. And the type of adjuvant, to me, I think this is not really recognized as well, but the type of adjuvant you have is really important for the type of immunity you launch. So, we've been using alum, which a lot of people, it's not really an adjuvant, it's part of the ingredients of Freud's adjuvant. But anyways, going down a long path there. But then the next are the component vaccines, where you take pieces of a bug and And then you also add an adjuvant and you use that to stimulate an immune response against these immunogenic types. And the new nucleic acid delivery platforms are ones we have just rolled. We never really used them previously, so it was a learning curve for them. But essentially, these type deliver genetic material, and the ones that we're using now encode the original spike protein of the Wuhan strain of SARS-CoV-2. And now, as an immunologist, I'm not really sure what the adjuvant for the mRNA is. I know they say it has its own adjuvant, but it doesn't really trigger the type of immune response you would typically have to a virus. And maybe that's why, or how it's presented to the immune system, because you can't really target it to specialized cells. You're assuming it's being uptaken around the muscle and being presented there. And so that might contribute to the variable durability of it.
Thank you, Dr. Callion and Mr. Davies. Next, Dr. Ellis, please, for 5 minutes.
Mr. Chair, I think it's Ms. Goodridge.
Ms. Goodridge, you have the floor.
Thank you, sir.
Thank you, Chair. Thank you, Dr. Callion. Well, thank you actually to all of the presenters. You guys have raised some really valid and interesting information for us to consider. Just to start off with, Dr. Callion, you talked in your opening remarks about how these mandates are impacting public trust. And I know as an MLA, or an MP in rural northern Alberta, it's something that I've been hearing quite a bit about. People that are really starting to question whether these mandates should be in place, specifically for domestic travel. While many of my colleagues around the table might be able to have travel by car to some of these locations, if someone in my constituency wants to go to Toronto, that's 3,600 kilometers. It's not really all that attainable to go by car. And so I was just wondering if you could possibly expand on the idea of how these public health mandates are now impeding on public trust, and what kind of ripple effects does that have?
Yeah, so I'm an immunologist, my expertise is not entirely around this, how one makes decisions around public health, but as a person, I feel that if I don't understand what the mandates are trying to achieve, and it was never really clear to me what was the purpose of the mandates, especially around freedom of movement. So if you're trying to prevent transmission, obviously the vaccines are not doing that right now. And imposing that on people, I think, doesn't really make sense to me. And you can see why it would increase resentment and mistrust, because that sort of heavy-handed measures doesn't serve any purpose other than building resentment and anger at a time where we can use more positivity, I think, than more negative. We want to make it's been a hard time for everyone, and I think we would want to make life as easy and less filled with resentment as possible at this time to really all recover together from this pandemic. So I really think that these mandates at this time should be lifted, especially for travel.
Thank you so much. And now I'm going to shift gears a little bit. Dr. Jacobs, you were talking about how wait lists have skyrocketed. I'm one of probably thousands of Canadians that had a COVID baby, and so I actually had to use quite a bit of diagnostic testing, which is pretty normal for most pregnant women. And I know getting just the routine ultrasounds was very challenging. Have you heard of any cases of people foregoing to get routine diagnostics or diagnostics that's impacted their health?
Yeah, absolutely. And the obvious one is breast imaging. So there we had, over the course of the pandemic, as I had said, 300,000 women who decided not to get screened. And as I said, that will have an impact on future breast cancer mortality. The other thing that we saw was more complex. What we were seeing were people not going to the emergency room despite having illnesses. So as somebody who would normally come to the emergency with some right lower quadrant pain was holding out, and by the time they got to the emergency room a week later than they should have, they had a ruptured appendix. That goes on and on and on. So we were seeing a lot more late stage cancers because people were just letting it grumble at home. And a 2-year period is a very long period to sit on any pathology. And now you have to then take that forward and say, okay, well, we have a 9-month wait list for MRI. That's an additional weight on people who've already delayed their treatment, delayed their diagnosis. So this will have a knock-on effect, to be certain.
I know for myself, there was a 6 to 8 week delay to get the dating ultrasound that needed to be done before 12 weeks. And by the time I found out I was pregnant, I was 7 weeks along. So it was virtually impossible to get the dating ultrasound. So, and that's just one small example. And it really required some creative thinking to be able to get that diagnostic testing. And I think it's so critically important. So do you have any messages for people that perhaps are delaying getting mammography? I think it's so critically important, and you have the floor. I'd really like it if you could perhaps say something to women to get breast cancer screening.
As succinctly as possible, doctor, please. You're on mute, doctor.
Without a diagnosis, there can be no treatment. Without treatment, you can't have your health. So you shouldn't delay. It's very safe to go to hospitals now, whether it be for breast screening, whether it be for anything. We're at the nadir of the Omicron wave. Don't delay your care any longer. Do come in, and you're quite safe.
Thank you. Thank you, Ms. Goodridge. Mr. Van Couverden, please, for 5 minutes.
Thank you, Mr. Chair. I'll just start by reading a quote from the Canadian Society for Immunology. We support unbiased, well-informed, and non-politicized scientific debate as vaccine rollouts occur with unprecedented speed. However, we strongly condemn concerted disinformation campaigns that misuse selected scientific data. These activities not only undermine the scientific process, but they also actively impair public health efforts and prolong the pandemic at great cost to us all. Based on the overwhelming evidence for vaccine safety and efficacy, we urge all Canadians to get fully vaccinated as soon as possible. Dr. Kalin, do you disagree with that statement?
No, I don't agree. Sorry for I got feedback. I certainly don't disagree with the feedback for having good, rigorous scientific discussion, and I think that has been lacking.
The question was pretty simple. Do you agree that Canadians should get fully vaccinated as soon as possible?
I believe it's the individual's decision, and I believe that education and understanding of the different types of vaccines and their efficacy and their safety, they should make that decision for themselves along with their doctors.
Thanks, Dr. Callion. Not to put you on the spot or anything, but if you'll indulge me, can I ask you if you've received a vaccine?
I prefer not to respond to that question.
Okay, thank you very much. Yesterday, 35 Canadians died from COVID-19, and about 4,000 are in hospital today. That's the same as the average between December 10th and March 10th. My question is to Dr. Wachowski. The typical duration of acute COVID-19 illness is 2 to 6 weeks. However, some patients have described debilitating symptoms persisting or recurring for weeks or months after acute illness. These longer-term symptoms are often referred to as long COVID, and we know that this condition can affect both adults and kids. Affected individuals are commonly referred to as COVID-19 long haulers. I have a couple of questions. Do you believe that the COVID-19 vaccines available to Canadians can help mitigate COVID-19? Do you think that they have a good impact on preventing long COVID symptoms in Canadians? And with the information with respect to the number of Canadians who have died from COVID-19 and how many are hospitalized? Do you believe that this pandemic is currently in an endemic phase?
Yes, thank you very much for the question, through you, Mr. Chair. So the National Advisory Committee looks at the effectiveness of vaccines. And as we know, if you don't get infected with COVID-19 because of vaccination, then you are not at risk for post-COVID syndrome or long COVID. So by being vaccinated, you are preventing getting infected to the extent that vaccines are able to do that. And we do know that 3 doses of vaccines do offer reasonable protection against infection. It does decrease over time, but definitely when you've gotten your 3rd dose, you're better protected than when you have your 2nd dose. So around 60% protection initially after vaccination with that 3rd dose. And the extent to which the 3rd dose will protect you from infection, it will also protect you from post-COVID syndromes. There are also some studies that are looking at the fact that even if you do become infected when you're vaccinated, in general, you're less likely to get post-COVID syndrome if compared to an unvaccinated person.
Thank you, Dr. Wachowski. I have a question for anybody who would like to take it. If Canada had the same death rate from COVID-19 as peer countries like the United States and the UK, instead of a devastating 27,000 Canadians who have died from COVID-19, we'd be looking at closer to 90,000 and potentially even more like 100,000 Canadians who had passed away in the last 2 years from COVID-19. How do we account for this difference? Obviously, there's multiple factors, but the question is open to the floor. What have we learned?
Who wants to take that one?
I can take that if you want.
Go ahead, Dr. Jacobs. You have a minute.
We've learned that vaccines work, public health interventions work, masking works. We have generally a very compliant society. We have a society that cares for its neighbors. We have a society that cares for the health of the elderly, and we have been very compliant both in getting our vaccines and in getting our booster shots. And I want to take this away from the basic science research and bring it back to the clinical world. When you have your vaccine, if you do get COVID, you do not get as sick. If you have been unvaccinated, you are disproportionately going to get extremely sick. So by our ability to counter misinformation and by our caring for our neighbors as Canadians are known to do, we have been able to keep our death rates much lower. The vaccines have been a medical miracle. The fact that we got them as soon as we did is fantastic, and they did exactly what we needed them to do.
Thank you, Dr. Jacobs.
Thank
you, Dr. Jacobs. Do I still have some time, Chair?
No, you don't.
Okay, thank you.
Suite, Monsieur Thériault.
Mr. Thériault, you have the floor. Thank you, Mr. Chairman. My question's for Amnesty International again. December 6, 2021, Pfizer says in an article that, according to the industry, lifting the patents would generate undue pressure on demand and the management of material that's already limited. It will discourage innovation, which has propelled the innovation of vaccines in record time. What do you have to say to that argument? Well, it's actually quite typical for a multinational pharmaceutical seeking profits at all cost. We don't give that kind of argument much credit. Perhaps my colleague has something to add to that. Yes, hi. What I would tend to say is that the assumption is that pharmaceuticals are in no way compensated. That's actually wrong. There is also an exemption. If there is an exemption before the WTO, whenever there is one, there's always some kind of financial compensation. So these firms would still be compensated. As far as we know, there are a number of derogations or exemptions before the WTO, and that has not prevented R&D. I could also say that most vaccines have been supported by public funding for the development, and that, it begs the question as to how these vaccines are being used, who can get them, given the global situation in a pandemic, which is really exceptional and requires exceptional measures. So these are not arguments that make sense, really, when it comes to public health. That's my answer. Thank you, Mr. Thériault. You have about 10 seconds left for a brief comment, if you like, but not enough time for a question and answer. Can I keep those 10 seconds for my next question? In a bank, with your indulgence.
Mr. Davies, please, for 2.5 minutes.
Thank you, Mr. Chair. Dr. Warshawski, I think I had promised to come back to you. What is your position or the position of NACI on using boosters for those who have infection-acquired immunity?
Yes, thank you for the question, Mr. Chair. So NACI does recommend that people who have had infection should be vaccinated. What they have recently come out with is some suggestions with regard to the time period between infection and vaccination. So they've said that if you had an infection, and you haven't yet completed or started your primary series, your first few doses, that you should wait 8 weeks from that infection to get your first or second dose of your primary series. And that's to allow that infection to help mount a good response from the infection, but then to enhance it with the vaccination, because we know that protection from infection can be variable. If you have a mild infection, you may not mount as good an immune response. And we know that protection against Omicron, if you've had Omicron infection, you don't mount a very good immune response against other types of COVID-19, against other variants. So it is very important to be vaccinated after you have been infected, but NACI recommends these intervals. So to wait, or they suggest to wait 8 weeks for your primary series. And then if you do for your booster, they suggest to wait 3 months between the infection and your booster, or at least 6 months between your primary series and the booster, whichever is longer.
So, Dr. Callion, having heard that, what does the data say to you about boosting people with COVID-acquired immunity?
Yeah, so there is really no data. So that's why the EMA and the WHO have not recommended getting boosters, especially with the original strain of the vaccines, because you're essentially, it's like recovering from the flu, and then you get a vaccine for the previous strain and boosting that response. So I don't have any data to suggest this would be a good idea. And what the data shows for people who have had COVID and recovered, that their immunity is pretty reliable.
So in terms of boosting, we know that the vaccines wane, and they give great coverage for a while, but they wane. And the European regulators have indicated that we can't be boosting ad infinitum, and that it may actually eventually be harmful. So what is the long-term game plan?
That's what I was hoping, that we would take a more responsible approach and wait for data, and at this time actually do what they're seeking to do, is to diversify their portfolio of the type of vaccines available. And I know there are a lot in the pipeline still. So one of the miracles of the mRNA vaccines was based on the fact that you can just pump them out super fast, and that gave them an advantage. So they could be a good filler. But at this point in time, if they were so good at coming up with new vaccines, then you would have thought that they would have already developed a variant-specific one, because right now Omicron is spreading because these vaccines don't show. It's an immune escape variant. So I think requiring more data and seeing whether or not it makes sense to actually vaccinate people who've already had Omicron and recovered, and see what the benefit of that is makes sense to me at this time.
Thank you, Dr. Callion and Mr. Davies. Next, Dr. Ellis, please, for 5 minutes.
Thank you, Mr. Chair. And on behalf of this committee, I'd like to apologize to Dr. Callion for the intrusive nature of my colleague's questioning with respect to asking you to provide individual health information. I apologize for that. Given that, Dr. Callion, maybe you could outline informed consent for this committee. I think that perhaps is germane. I know that you spoke a bit about it in your preamble, but maybe just the 3 or 4 points around informed consent, if you would, Doctor.
Yeah, it's the fundamental piece of any kind of medical intervention that a person understands their own personal risk from the intervention and their own personal risk from the disease in question. And so I'm not sure if everyone has been given, because it's an evolving science, especially around the new platforms, which are very promising, but we don't have very good longitudinal data. And so that's still coming in. And so to provide actual informed consent is challenging right now, because people's risks for both the disease is very disparate, as well as adverse effects. And we saw that, quickly. We moved quickly with the adenovirus vector vaccines when we saw that VITT, and especially in women, that it became less used in Canada, but we haven't really moved as quickly on the mRNA vaccines for young men, for example, and advising them appropriately.
Thank you, Dr. Callion. I'm going to shift gears a little bit to Dr. Cohen, if I might. You talked a little tiny bit about increasing vaccine uptake with dialogue and education, and also about how healthcare providers speak to individuals. And I'm wondering, Dr. Cohen, if you might comment on the federal government's use of disparaging and dividing language with respect to how that might increase uptake. Dr. Cohen, if you would.
I think one of the key messages for some of the research that looks into why people are hesitant to get vaccines is that there's not a single reason. And Dr. Lavoie's research suggests that there are a few categories of people who resist vaccine. It might be some folks need more information. For some folks, it's much more practical. They have difficulty leaving work, getting childcare to go get vaccines. And for others, it really might have to do with confidence. The way in which healthcare providers speak to their patients about their concerns really impacts how they follow up on their advice. I'm sure my medical colleagues here would agree with that the better someone understands their disease and their treatment options, the better informed decision they're going to make. So I think the takeaway, though, the important takeaway of the behavioral science research is that there's many reasons why people may be hesitant to get a vaccine, and what you do about it depends on the reason they have.
Thank you, Dr. Cohen. Is it safe to say that perhaps calling them names is not that useful?
Well, for many psychosocial reasons, calling anyone names is not useful.
Thank you, Dr. Cohen. I appreciate that. Back to Dr. Warshawski, if I might. My colleague talked a little bit about doses in the future, vaccine durability, how many doses we're going to need. Dr. Warshawski, could you speak a bit, if you would, about kind of the future of vaccines and what it may look like in terms of variants and how many doses we're talking about? I believe Israel's on dose number 5.
Yes, thank you very much, Mr. Chair. So NACI advised, the National Advisory Committee on Immunization, we monitor the authorized vaccines, or the vaccines that we expect to be authorized, and make recommendations with regard to those vaccines. So we're currently looking at the current vaccines and how we can make best use of them. As new technologies become available, so if we get future technologies that may, for instance, look at mucosal vaccination or vaccines that enhance other parts of our immune response, like T-cell immunity, then as those vaccines become authorized in Canada, NACI will look at those vaccines as well and make recommendations with regard to them. So we know, the whole scientific community is watching to see what the next types of vaccines will be. They're watching what the manufacturers will put out with regard to potentially multivalent vaccines, so vaccines that cover the wild type strain and the Omicron strain, and whether those may be more beneficial for future boosting. And as those become authorized and the manufacturers put those forward for authorization, we will then, within the National Advisory Committee, look at those as well and make recommendations in the context of the epidemiology and the other vaccines available for Canadians.
Thank you, Doctor. I appreciate that. Madame Langlois, I'm unsure if this is within your ability to answer, but can you comment a bit on Canada's contribution to the COVAX program and how we've done with respect to that?
Briefly, if possible. I'll turn to my colleague, Colette Lelièvre. Yes, hello. So, look, I don't have the most recent figures. Canada is a participant to the COVAX process at a rather high level. Canada has promised a high number of doses. I don't have the most recent figures. I know that there are, of course, issues between an announcement and the delivery of COVAX vaccines internationally. I don't know where things stand, but I know it's an important issue. We would like the delivery to be more predictable and regular. So that is a critical issue. It's important. We would like to see Canada use processes like COVAX to distribute vaccines that have been ordered or are excess, for which there are excess numbers, because it allows for a fairer system globally for those countries that don't have the means to buy vaccine doses for their own people. I'm not sure if that answers your question, but that's the knowledge we have at this point on that one. Thank you very much, Madame Lelièvre.
Next, Dr. Hanley, please, for 5 minutes.
Thank you very much, and thanks to all of the panelists. Briefly, Dr. Warshawski, first of all, having been in the game for a while, I want to recognize the incredible work that you and other members of NACI have been performing during the last 2 years, often under incredible pressure. I wondered on sort of at a high level and as briefly as possible whether you could comment on some of the challenges associated with translating data during a pandemic into policy and vaccine recommendations.
Yes, thank you very much for the question. So, yes, definitely some of the challenges have been the paucity of data. So at the beginning, we often don't have a lot of data. We have the clinical trials, but they are done in specific populations and on relatively small numbers. So we have to make our best recommendations with the available information and then continue to monitor the ongoing information that comes from real world use. So effectiveness trials and safety trials in the real world. And then we incorporate that back into our recommendations and revise them if needed. So it has been an ongoing iterative process of being, trying to make the best recommendations with the available information and then staying on top of all the evolving information and modifying as needed.
And I must say, I think you've been very nimble in doing that. Could you also summarize, in your understanding, the current state of understanding of natural immunity versus vaccine immunity with regard to the Omicron variant?
Yeah, thank you for the question. So with regard, if you've only had Omicron as your only infection, you mount a response against Omicron, but it doesn't provide a very broad response against other types of variants, the past ones, or potentially, we don't know what future will look like, but against past ones for sure. However, if you have vaccine-induced immunity and infection on top of that in whatever order, and in fact, they say if you've had 3 exposures to either vaccine or a combination of vaccines and infection, that gives you the most solid protection. So it seems to be this 3 exposures to the SARS virus or vaccine that give you really good solid protection. So relying on infection alone, there's variability. It may not last and it may not be very broad. And so you really get this solid protection when you have either 3 doses of vaccine or a combination of vaccine and infection.
Yeah, that certainly speaks to the complexity behind this and the potential, I guess, that how easily one can be misled by sweeping statements on natural immunity versus vaccine immunity. I wonder, and briefly, whether you could talk about the additional value of recent vaccine products, particularly the virus-like particle vaccines, and what potential they offer in months and years to come in terms of broadening our array of vaccines.
Yep. So thank you very much for the question. So as you know, recently there's been 2 new vaccines authorized. One is a protein subunit vaccine, so the Novavax vaccine, and the other is a viral-like particle vaccine, which is the Medicago vaccine. Particularly Medicago is a new technology based on growing the virus, the vaccine in plants, and so that's a very interesting new technology. NACI has made recommendations with regard to both those vaccines. They've expressed a preference for the mRNA vaccines, which we have been using for a long time and which we have a lot of comfort with regard to their effectiveness and their safety. So they've expressed a preference for those vaccines. While data accumulates for the other vaccines, they have certainly said that if someone doesn't want an mRNA vaccine, that then the Novavax or the Medicago vaccine are options that they can take as well. But we have a lot more experience with the mRNA vaccines right now, so the preference is for those vaccines. And as mentioned before, we'll get more information about these newer vaccines, and NACI will adjust their recommendations as needed.
One more minute. To Dr. Jacobs, thank you very much, Dr. Jacobs, for your really interesting presentation. And lots I could ask. Perhaps the most useful question might be how you as a hospital are looking at what you've learned to prepare for what might be the next threat, whether that's another variant or another virus, how you would, as a hospital, use this experience, maybe I'm sorry, but very briefly, into being able to incorporate the ability to see patients.
Short response,
so basically,
please, Dr. Jacobs.
Oh, sorry. What we must do is we must preserve our capacity to treat all patients. And we must increase our capacity to treat patients who are sick from severe viral illnesses. That basically has to impact how we think about the virus, our ability to adjust our risk tolerance, and it also has to do mostly with manpower issues. So going through it very briefly, we are desperately short on ICU nurses. We need to have some sort of a program whereby we can have nurses who are able to slip into the ICU as necessary. That's very difficult because it's highly specialized care. The alternative is that we have an overabundance of ICU nurses, which is a very expensive proposition. We have to choose, though. We can't not have one or the other. With regards to keeping our capacity, what we have to recognize is that low-risk procedures have to continue throughout the pandemic. So we can either do those in facilities outside of the hospital, or we can recognize that the risk is quite low and we just soldier on, knowing that there will be some patients who are exposed to whatever virus comes next or whatever wave comes next. But we can't just stop cold anymore. This is a very complex issue, and I'm not sure that we're going to have time to dive into that right now.
Maybe someone else will lead you to continue the discussion. Thank you, Dr. Jacobs. Next, we're going to go to Mr. Lake, please, for 5 minutes.
Thank you, Mr. Chair. I'm going to dive into something that's kind of complicated, and I've got to try and get my own head around the way that I frame it. So when we're talking about the evidence base around vaccine mandates, oftentimes we're having debates here in the House about mandates, not so much the evidence base around vaccines. I think there's a fairly widespread, maybe not unanimous, but very widespread amongst 338 members of Parliament agreement around the evidence on vaccines. My question is for Dr. Warshawski. Does NACI advise the government on evidence around vaccine mandates particularly, or is the decision to mandate vaccinations more of a policy decision based on the evidence around vaccines?
Thank you for the question. NACI does not make recommendations with regard to mandates. NACI makes expert advice with regard to the use of vaccines, which products, to which populations, but mandates are a federal, provincial, or territorial decision.
So the decision to mandate, though, would be more of a political decision based on the advice you give around the efficacy of vaccines?
That's right. NACI would provide information on how well vaccines work and what their recommendations for vaccines, but they wouldn't provide information or advice on whether to mandate or not. That would be within the realm of the provincial and territorial and federal policymakers.
Okay. And my next question is around the most effective arguments to convince Canadians to get vaccinated. And this can be for anybody on there. What in your view, and maybe this goes more directly to the doctors on the panel today, what on your view would be the most effective arguments to convince Canadians to get vaccinated, folks that for whatever reason haven't at this point in time? Maybe Dr. Jacobs, just to start, because you've spoken to it a little bit, and it sounds like you're very adamant that it's important that people get vaccinated. What would be the most effective arguments to convince those that aren't?
Well, at this point, many of the people who are not vaccinated are in smaller groups, smaller communities. And I think if we're really going to get those people to get vaccinated, we have to reach out to them with very specific programs, whether it be a religious group, a cultural group, and you have to get in there and give them the information that they need to make an informed decision. So it's a ground game at this point. Earlier on, we're always a little handicapped by patient privacy. If I could have shown people what I saw on imaging, if I could have talked to people directly about cases, I have no doubt in my mind that many people would have run out the next day and gotten vaccinated. I saw things that I had never seen in my career, and I've been doing this for a couple of decades now. I saw people on ventilators with torn lungs. That's not something that you see normally. So this has been an incredibly serious illness. But because of patient confidentiality, because of patient privacy, we're not able to speak freely about the impact on patients. I wonder if we had some way of getting around that, that we would have been able to better share the seriousness of the illness. But it's always a balance.
So fair to say that if Canadians better understood the health impact, they would make better decisions. Is there any evidence that anybody has that the argument that that most people who have chosen not to be vaccinated are misogynists or racist, that there's any evidence to point to the fact that Canadians who aren't vaccinated, many of them, to quote the Prime Minister, are misogynist and racist? Is there any evidence to point in that direction? And number two, the second part of that question would be, is there any evidence that making that argument convinces people to get vaccinated who haven't chosen to get vaccinated already?
It was a uniquely unhelpful thing that the Prime Minister did when he said that. It was politically driven. It did not help anyone in the healthcare industry. It did not convince anyone to change their mind. The people who remain unvaccinated right now are very much a mixed bag of people. Some of them are unvaccinated because they've looked at the research and they don't, and they disagree with the findings that the majority of healthcare workers and scientists have come to in terms of conclusions. And there are other people who are just simply afraid. There are other people who have been misinformed by social media. It's quite a wide array of people, and name calling is not helpful.
Thank you, Dr. Jacobs. Mr. Lake. Next, Mr. Johari, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all our for joining us today and for your comments. I'd like to take the conversation a little bit of a different way, different direction. So I'd like to talk about the potential pandemic, which is not virus-based, and we may not have a vaccine for it to be able to debate. And I'd like to talk about mental health. So, Madam Eaton, welcome to our committee. In your opening remarks, you talked about the fact that 64% of the people in Canada are worried about new variants. I had actually an opportunity to read the survey that was put out by CMHA. My compliment, great job. In that survey, the finding also pointed to some other type of threats or concern, such as climate change and concern people had about their employment. Can you shed some light about these findings and share with us some of the percentages or some of the data result that you found?
Yeah, thank you so much. When we looked at sources of stress, financial was 30% of Canadians feeling worried about money. Even though this was later, the findings were taken just before Omicron. They were also very worried about the mental health of their children. 21% mentioned children. 16% of people were worried about having enough food. And when we looked at those vulnerable populations in particular, we also saw suicidal ideation was up. So in a normal year, 2.5% of Canadians have a suicidal thought. The average number across the last 2 years was 8 to 10% of Canadians having suicidal thoughts. And if we look at those vulnerable groups that I mentioned, Indigenous people, LGBTQ, we saw that number go above 10%. So people are really struggling through this time.
Thank you. You pointed out 4 recommendations, and as you were providing your testimonies. The first one was around long-term funding. And just want to go back to the government record over the last 6 or 7 years. In 2017, I believe we allocated $5 billion over 10 years. And in budget 2021, there was an allocation of about $100 million over 2 years, specifically around innovative mental health intervention for population disproportionately impacted by COVID-19. Now, in your statement, you also caveated with how we have to work with provinces on a jurisdictional basis to make sure that these funds are properly allocated. Can you expand on that one, please?
Yes, we were delighted that the federal government had identified a few years ago billions of dollars to support mental health. But unfortunately, we don't really have much information about how that money was spent. And so we know that there is underspending on mental health. And when we look at investment in community mental health, it's even lower. So we were very excited to see the creation of a mental health transfer and the opportunity there to fund community mental health through the mental health transfer. So we're very excited by this idea that there would be standards set around mental health and that those standards would be tied to this mental health transfer to ensure that community mental health gets funded, but also that we can make sure that there is a standard across the country of care. And so that if you live in Newfoundland, you're going to get the same quality of care that you would get in Ontario. And that isn't the case right now. So we're very excited to see standards and to see a much higher investment, particularly targeted and if you will, to mental health investment.
Thank you. You talked about community mental health organization. I also noticed that you had put a report out on March 2022, which talked about the burnout for these community-based health organization as it relates to mental health. Can you share some? Can you brief us on the finding?
And if you could
Yes,
briefly brief us, that would be helpful. Thank you.
When we spoke to our COVID or to our branches across the country, people talked about the fact that the demands for service had gone so high that there were waiting lists in most of the areas that we were looking at. So CMHA Toronto, there was a 300% increase in demand for youth programs. CMHA Edmonton, there was a 200% increase in calls just related to income support and employment needs. And what our CMHA workers found was that they were being asked to do things way beyond mental health. They were asked to help provide food. They were volunteering at vaccine clinics. They were doing everything they could to make sure that their communities were healthy and cared for. And because our our community mental health organizations are underfunded at the best of times, it just meant that this incredible demand with phones ringing off the hook has led to burnout for a lot of our workers. And if we look at things like nurses that work for CMHA as compared to hospitals, they're underpaid as compared to hospital-based or private nurses working in mental health care. So we've got an underpaid, overworked healthcare worker in mental health, and we believe that things like investment in community health would go a long way to mitigate that.
Thank you, Ms. Eaton. Thank you, Mr. Johari. Monsieur Thériault pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Thank you. Ms. Langlois and Le Lièvre. I have a question for you. How do you assess the position or the posturing that the federal government has with respect to the point that you were raising about the WTO? In other words, over the last 2 years, do you feel they're walking the talk? And that's the second question now is you mentioned supply chain issues, infrastructure issues, or lack thereof. What should the government do to really contribute it to the level of your expectations? Canada's position before the WTO is a supposedly neutral position. As far as we are concerned, Amnesty International feels that it's actually an impediment. It prevents an agreement on a temporary lifting of patents, and we really, really need that to be lifted. There needs to be a sharing, transparency as to these recipes, as I say, and other technologies, whether we're talking about vaccines or any other product, that be shared broadly to reach out to as many people as possible. Colette, my colleague, said this, but it's not true. It would be unfair to say that Canada is doing nothing. Canada is taking part in COVAX. It could do more on that front, and it could really deliver on the promises that have been made. Canada could play a leadership role internationally when it comes to logistics, for one. When we talk about these patents and lifting of these patents, and we're focusing almost strictly on vaccines, and in the meantime, logistical systems are not being set up in these countries that really require vaccines. And this is preventing vaccines from actually being deployed in these areas. There's this whole awareness raising or education side that has to be done to convince people, these populations, to turn to vaccines or treatments that could be available to them. Colette, did you have anything to add to that? Oh, thank you, Madame Langlois. Can I add one little thing? Short, if you can, briefly. Actually, Canada could also support healthcare systems in countries that we're working for on the international development front. That would mean that these countries could be better prepared to then distribute the vaccines fairly throughout their country. That would require enough support when it comes to staff or the supply aspect within the country, just maintaining the cold chain, these types of things. So substantial support from the federal government would certainly help globally. So healthcare systems can have the capacity to react quickly once they receive these vaccines or treatments from these pharmaceutical industries. Thank you.
Davies, please, for 2.5 minutes.
Thank you. Dr. Warshawski, we know that vaccines wane. I think I've already mentioned about the European regulators stating that we can't boost our way ad infinitum, and that potentially that boosting may actually be may cause tolerance, I think is one of the terms they use long term. So assuming that the boosters wane over time, what's the long-term game plan after that?
Yes, thank you for the question. So currently, as you know, the manufacturers are looking at different, including different variants in their vaccines. So in the shorter, in the next few months, we may see different variants included. So they're looking at both the original strain, the wild type strain, and potentially the Omicron strain. So that's the nearest strategy. We're also, as mentioned, looking at other types of vaccines. So potentially mucosal vaccines that are delivered in the nose or in the mouth that will enhance the vaccine protection that we got from an injectable vaccine and potentially provide more protection against infection. So this research is all ongoing. And I think we need to take each wave as it comes and the epidemiology as it comes, see what products are available, and then NACI will make their recommendations, keeping all that information in mind.
What's the current state of knowledge about efficacy, say 3 months out after booster? So I got my third booster in January. What would you expect my efficacy to be 3 months after that?
Yeah, so a very good question. Thank you for the question. So with regard to infection, the booster gives you around 60% protection against infection. But over time, so about 3 months later, it will have fallen. Exactly what it will be, we don't know, maybe 40%, maybe 30%. But most importantly, it's about severe disease. Like we are really vaccinating to prevent severe disease. That's the main goal. So if you talk about promoting vaccine for people, it's about keeping you.
I know that's why, doctor, but how long will that last?
Yeah.
I mean, if it's June and I'm 6 months out after being boosted, what is the efficacy of the vaccine to prevent me from serious illness at that point?
For sure. So we know that once you're boosted, you get into the high 90s in terms of protection against severe disease. We don't know. We know that will last. For the most part, seems to be lasting a number of months, but we don't have data for months and months and months. So like 3 months out, for the most part, the studies are still showing good protection, mostly 70 or higher, and many still in the 80s and 90s. But we need to go out longer to see what the protection for that longer term will be.
Thanks. I'll squeeze one last question, Dr. Callion, on if I just give you a last word on
Mr. Davies, you're out of time. I'm very sorry.
I'm sorry. Thanks, Mr. Chair. No, that's okay.
Trying to get a sprint to the finish, get the last 2 rounds in. So Dr. Ellis has the floor for 5 minutes.
Thank you for that, Mr. Chair. I appreciate that. A question for Ms. Eaton, if I might. We did delve a bit into the mental health issues associated with the stress of COVID and the mandates and lockdowns, et cetera. We talked about chronic stress that Canadians are under. One of my questions is really related. Do you think if the government had a plan going forward with respect to federal mandates, that may go some distance to alleviating the stress that Canadians are feeling chronically at the current time in leadership?
Sorry, just to clarify, if the federal government...
A plan. If they would communicate a plan to Canadians with respect to federal mandates, do you think that may go a long ways to alleviating stress, or am I off base there?
I think most Canadians are concerned about their day-to-day lives around, do they have enough money to make ends meet? Can they see their family and friends? Can my kids go to school? A lot of these issues are provincial, in fact, not federal. And I think that there is a little bit of relief of some of that stress now, as we've seen most provinces are starting to open up. And I'm hoping that will alleviate some of the stress. But I think in terms of chronic stress, we're going to have a kind of PTSD response to COVID-19. And some people will not even begin to experience some of the mental health impact until after things do go back to normal. And then they'll start to feel the crushing weight. We'll also experience the long COVID impacts on mental health, which we're starting to see. And so we believe over the next 2 years will be the time that we're going to have to deal with more phone calls, more walk-ins, more concerns expressed by people about their mental health.
Thank you for that. You talked a bit previously about virtual care with respect to mental health services, and perhaps it was Dr. Cohen. I may have got that mixed up, and I apologize. Is it as effective as in-person service?
There's lots of data now to suggest that virtual is very effective. Our only concern with virtual is that not everybody has access to broadband internet. Not everyone has access or can afford the devices that would be needed to actually take advantage of it. I'll turn to Dr. Cohen, who has a comment.
Thank you. Yeah, no, I would agree entirely with Ms. Eaton that there certainly is evidence that care for certain problems delivered virtually can be as efficacious as person-to-person care, but there are still huge inequities in people having access not just to technology, but to the personal and private space to have that kind of care. And I guess just two quick points, if I may. One is around accessibility. I think there are huge inequities in terms of access to mental health services pre-pandemic. A pandemic that brought about all these mental health concerns only places a further demand on a system where not people have sufficient access. And the second point is that we tend to treat mental health as if there's one problem and one solution. There are a great range of services. Some are delivered by community programming like the CMHA. Another person might need peer support. Another person might need assessment or psychotherapy. There's a range of problems and a range of solutions that Canadians need better access to.
Thank you both for that. I wonder, Dr. Cohen, since we've got you on the hot seat, if you might comment on the three-digit suicide prevention hotline and the necessity and urgency to have that in place.
I think any care that we can offer people in distress is a good thing, but we have to be able to provide that follow-up care. Emergency response lines are important, but what's more important is the care that's delivered behind it. Mental health problems, by and large, are not ones that are, there's not many where it's a single session and it's resolved. We need to be able to provide that follow-up care.
Fair enough. And certainly I would suggest there's significant inequities in terms of the system with respect to folks who choose to live rurally and often are disadvantaged previously. Finally, if I might, maybe we should talk a bit about the opioid crisis that certainly has accelerated during the pandemic and has caused significant problems. I'll leave it open, Dr. Cohen. I'm feeling magnanimous. Maybe if you could just give us some words on the opioid crisis, if you would.
Well, that's not my area of expertise, but I think we've certainly seen increases in use of substances, particularly around people who may have already had concerns or issues with the use of substances, and that kind of care, those kinds of interventions for mental health problems or substance use, I would say both need more investment, and we need to invest in them with parity, the way we provide care for physical health problems.
And do I have any more time? I'm done.
No, you do not.
Thanks, sir.
Thank you, Dr. Ellis. Thank you, Dr. Cohen. The last round of questions will be posed by Ms. Sidhu, please, for the next 5 minutes.
Thank you, all the panelists, and your testimony. My question is to CMHA. Thank you very much the work you're doing for the community. 1 million people you are reaching out with the 318 branches. Thank you, all the frontliners. I just want to, federal investment of more than $240 million announced on May 3rd, 2020, including support of Wellness Together Canada. Health Canada's department report, as of January 2022, the Wellness Together portal had been accessed by over 2 million Canadians, with many people reporting positive changes in the self-assessment skills. Do you think, can you speak to the success of this system, what you would like to see improved, and the role you see, how is effective?
We were really delighted to see Wellness Together and to see the federal government make that investment. It was very important. And it provides a huge selection of supports, both virtual, and it even includes in person. So there were a few hours of free psychotherapy that were offered to people. So we think that that was an absolutely important and necessary response to the pandemic that the federal government could uniquely make to have a national service. And we've been very pleased to see that it will be carried on. My only enhancement that I would make is that I think there needs to be more promotion of that service. More people need to know about its availability. I think it can really fill a gap and will continue to. I know the government is interested in seeing it carry on, and we are interested in seeing its continuance as well.
Thank you, Dr. Eaton. The next question, either Dr. Cohen or you can take that. Obviously, we know that there's a lot of there's a chronic stress out there, and even though seniors' mental health is also, we should talk about that too. But the federal government recently appointed the first federal minister of mental health with the goal of creating mental health transfer payment distinct from the existing Canada health transfer. With this in mind, do you feel that there needs to be more collaboration between mental health providers and the mainstream medical system, or should there be more focus on community and peer support?
Great question. One of the things I mentioned in my opening remarks is that we came together with our provincial association partners of psychological associations with a paper to suggest how a mental health transfer, a federal mental health transfer, could be invested in the provinces. And we strongly support the integration of mental health services, psychological services into primary care. That's the funded door. That's the door where most Canadians first have access to health providers. Integrating mental health services there makes a tremendous amount of sense, and doing it in a way where there's some kind of parity in funding for services delivered.
Thank you. And my next question to Dr. Eaton, you can answer me on that. Virtual care. Many physicians offered phone and online virtual appointment. These practices also referred as a telemedicine. What are your observations with respect to overall uptake or any acceptance on the phone? If do you think it's helpful? Because I got lots of positive feedback from my residents.
Yes, I believe it was very helpful. Many of our CMHAs pivoted to provide virtual services, and it was hugely beneficial to people, especially, as you say, seniors, people who were under lockdown and did not have access to in-person. In fact, it's been so successful across the country that our branches are going to continue to provide virtual services, even while they're opening up their doors to clients once again on a more regular basis. So we hope to continue to be able to provide that and to have funding for that, not just for the actual caregivers, but actually place the technology into the hands of our clients for those who need it, and to be able to provide that internet access.
Thank you, Ms. Eaton, and thank you, Ms. Sidhu. To our witnesses, that concludes our rounds of questions. I want to thank you for your patience in waiting on us while we exercised our democratic duty, for your professionalism and the depth and breadth of the knowledge that you've contributed to this discussion today. It was a varied and robust panel. It will add greatly to the value of our work, and we are extremely grateful for you to be with us here today and to answer our questions so comprehensively, professionally, and patiently. So thanks once again for being with us. Greatly appreciated. Is it the will of the meeting to adjourn? We're adjourned. Thank you.